Welcome to the Talking Ketamine podcast, the show where we explore the science behind this fascinating molecule. This is episode 41, Ketamine for Catatonia.
Thanks for joining us. Today we're discussing a condition that is often misunderstood and terrifying for those who experience it. Catatonia. And specifically, a new systematic review that asks if ketamine can help when standard treatments fail.
And that really sets the stage for a critical deep dive. We aren't just talking about, some psychiatric curiosity here.
Oh, not at all.
We are talking about a severe, life-threatening neurological state where the traditional psychiatric tools, the ones clinicians have relied on for decades, have failed.
Right.
So our mission today is to understand what happens when a patient is essentially frozen and why an NMDA antagonist like ketamine suddenly becomes maybe the only hope.
It's a classic example of a critical unmet need in medicine. And the evidence base, it's small, but it is highly compelling.
Okay, so let's start with the condition itself, catatonia. It often brings up these images of someone just being completely rigid or frozen. But for someone joining us, what is the full scope? Is it really just about immobility?
It's far from it. While immobility is definitely a feature, catatonia is a much more complex cluster of signs. It's a profound impairment of movement and behavior.
So beyond just stupor.
Exactly. Beyond stupor, which is that lack of response to things around you, you see features like mutism, which is the complete inability to speak.
Wow.
And something called negativism. That's where the patient actively resists any attempt to be moved or any instruction from a clinician. There's also this marked withdrawal. It's a syndrome that puts the patient in immediate physical danger. They often can't feed themselves or do anything, really.
And that's crucial. Where does it come from? Because I think historically it's always been linked to schizophrenia, but the data seems to be telling a different story now.
That is a really key distinction. While it can occur in schizophrenia, the case reports we're looking at today, they just reinforce this finding that catatonia is very frequently associated with primary mood disorders.
Like depression.
Especially major depressive disorder or bipolar disorder. And understanding that underlying cause is it's vital when we choose a treatment. You want something that addresses the immediate crisis and the chronic illness.
Which brings us to the neurochemistry of it all. We're talking about a breakdown in the brain's communication, and the sources point to two main players, GABA and glutamate.
Exactly. The accepted pathophysiology involves dysregulation in both the brain's main inhibitory neurotransmitter, GABA.
The brake pedal.
The brake pedal, right?
Yeah.
And the main excitatory neurotransmitter, glutamate.
Oh, gas.
Yep. The interplay between those two systems seems to be where that catatonic state really locks in.
Okay, so a patient presents in this crisis. What's the standard playbook? What's the protocol clinicians follow before they would even think about something like ketamine?
Well, the standard protocol is pretty clear and sequential. First-line treatment involves a GABA agonist.
A benzodiazepine.
You got it. Typically lorazepam. The approach is basically to try and boost that inhibitory GABA system, the brake pedal, to calm the brain.
And how well does that work, generally?
The success rates are actually very high in the general catatonia population. We're talking somewhere in the range of 66% to 100%. So it often works.
But when it doesn't, if that GABA approach fails, what's the second-line treatment? What's the heavy hitter?
That would be ECT.
Electroconvulsive therapy.
Right. If the medication doesn't break the state, ECT remains a highly effective and proven second-line option for resolving catatonia and resolving it swiftly.
And here's where this paper really hones in on that clinical gap.
Yes.
So if lorazepam has failed, and now we're supposed to rely on ECT, what are the real-world obstacles that put these patients into that refractory category, leaving them locked in this state with no obvious solution?
This is the high-stakes moment. Patients who don't respond to lorazepam are extremely challenging. But the reason ECT isn't an option often just comes down to physical health. ECT requires general anesthesia, and the induced seizure puts significant stress, though it's temporary, on the cardiovascular system.
So it's not just a patient being unwilling, it's that it might be medically unsafe.
Exactly. The case reports we're looking at showed patients who were just too medically unstable. Maybe they had severe cardiovascular disease, or were on strong anticoagulation meds, or had severe cardiomyopathy.
You can't risk their life with an acute cardiac event just to treat the catatonia.
Precisely. And there were other factors, too. Logistical things, like just limited access to facilities for ECT.
Yeah.
This became a huge problem during crises like the COVID-19 pandemic, which was noted in a couple of the cases.
So when the GABA approach fails and the powerful second-line option is off the table, The clinician has run out of options.
They have run out of established options.
Yes. And that's the desperate scenario this systematic review is looking at. Clinicians, faced with this, turn to more exploratory evidence. So tell us about the data they pulled together.
So the researchers did a systematic review of existing literature, and they were looking specifically for case reports where ketamine or esketamine was used to treat catatonia.
Okay.
They gathered data on 10 unique adult patient cases from 9 different articles, searched up to early 2025.
So it's very recent.
Very. And for a rare and dangerous condition like this, while it is a low level of evidence, synthesizing these reports is absolutely vital for maybe developing future treatment guidelines.
So who were these 10 people? What did the population look like?
Well, the patients ranged in age from 23 to 81, and there was a really strong female dominance. 9 out of the 10 cases were women.
Interesting.
And the underlying diagnosis was key. Major depressive disorder accounted for half the patients. And critically, 6 of them had already failed lorazepam, and only 3 had even attempted ECT, which really confirms they were in that true refractory population.
And their symptoms were classic. Stupor, mutism.
Stupor, mutism, withdrawal. All the hallmarks.
Okay, and the intervention. Was there a standard way they delivered the ketamine?
No, not at all, which is what you'd expect from case reports. The dosing and the delivery routes were highly variable.
So it was kind of all over the place.
It was. Patients received either racemic ketamine, which was given racemic, sublingually or intramuscularly, or they got the newer formulation, intranasal esketamine. Doses were, they ranged widely, for example, from as low as 10 milligrams of 5E ketamine up to 84 milligrams of esketamine.
Okay, let's get to the results because they sound striking. You have patients who have failed the gold standard drug. What happened when they introduced this NMDA antagonist?
The key finding was, well, it's pretty much unprecedented for this population. Symptom improvement was observed in all 10 patients.
Wait, all 10? Every single one?
All 10 patients included in the review. That 100% response rate, even across all these different cases, it's profoundly significant.
Improvement within hours is it's unbelievable for a complex state like this that has resisted treatment.
It is.
Does that rapid response suggest that catatonia, at least in these cases, is maybe a more acute reversible switch than we thought?
It absolutely does. The sources noted that improvement often happened within hours to days after giving the ketamine.
Wow.
This rapid reversal suggests that the NMDA antagonism isn't, gradually fixing a long-term problem. It's more like it's flipping a highly dysregulated circuit back into its functional range.
So how did that translate clinically? They used something called the Bush-Francis Catatonia Rating Scale, the BFRS. What does a 50% reduction in symptoms on that scale actually mean for a patient?
That 50% marker is what we call a significant response. So for a patient who is in severe stupor, who is mute, getting a 50% reduction means they went from rigid immobility and complete unresponsiveness to being able to track movement, maybe communicate basic needs like hunger or pain, and follow simple instructions.
It's a massive step.
It's a huge step toward recovery and just life stabilization. Specifically, 4 of the 6 patients where they used that scale achieved that significant response within just 1 week.
And what about full recovery? Getting back to normal?
Full remission, so the complete absence of catatonia symptoms, was achieved in 4 patients overall, and 2 of those got there within the first 2 weeks. It's essentially a life raft when the traditional vessels have already sunk.
This brings us to the core concept here, the mechanism. Why does ketamine work like this skeleton key? When lorazepam, targeting the GABA system, failed, why is switching from GABA to glutamate so effective?
It's because we are basically abandoning the inhibitory pathway and directly addressing the excitatory one. Lorazepam tries to calm the system with GABA, but in refractory catatonia, some theories suggest the underlying issue is a massive hypo-functionality of the glutamate system.
So the brain's main engine just isn't firing enough.
It's not firing enough to sustain normal activity, which leads to that rigid frozen state.
So if the engine isn't firing, pouring more brake fluid, more GABA on it isn't going to help.
That's a perfect analogy.
Yeah.
Exactly. You need a different kind of intervention. And ketamine, as an NMDA receptor antagonist, provides it. By blocking that receptor, it causes a surge in glutamate release in other parts of the brain, especially the prefrontal cortex.
Ah, okay.
And this powerful surge seems to effectively reset those rigid circuit patterns that are responsible for the catatonic state. It just overcomes that stillness, which explains the speed. It's a dynamic change, not a gradual one.
So the strategy is key. When one neurotransmitter system fails, you attack the problem from the complete opposite chemical direction.
It reinforces the validity of this entire class of drugs as, say, third-line agents. It lines up with how other NMDA antagonists, like amantadine, are sometimes used as a last resort.
Yeah.
But ketamine has advantages in both speed and practicality that the others just don't match.
Okay, let's talk about that practicality, because you said that's a critical point in an emergency.
The practicality it cannot be overstated. Catatonic patients, they often resist everything. They're mute, they're withdrawn. They might actively fight medical procedures.
So you can't get them to swallow a pill.
Impossible. And even starting an IV line can be incredibly difficult. What's so fascinating here is that ketamine offers these highly diverse administration routes for IM, sublingual, or intranasal esketamine.
And the nasal spray seems like a game changer.
It is. The intranasal formulation in particular lets us just bypass that whole crisis of resistance. You can deliver a rapid-acting medication without needing full patient cooperation.
And since major depressive disorder was the main underlying diagnosis here, ketamine seems to offer this unique two-for-one solution.
That synergy is a huge clinical bonus.
Yeah.
Esketamine is known for its rapid antidepressant properties. So in these patients, you get the rapid anti-catatonia effect, you break the stupor, and you simultaneously start treating the underlying depressive illness. A benzodiazepine just can't do that.
It's addressing the immediate threat and the root cause in one go.
In one go.
We have to talk about safety, though. Especially with these medically fragile patients, isn't there a huge concern that ketamine could destabilize them? Make psychosis worse in someone with schizophrenia or triggermania in a bipolar patient?
That is a very serious and very common fear among clinicians, a valid one. However, this systematic review, it analyzed those outcomes specifically.
And what did they find?
The finding was that the concern that esketamine might exacerbate mania or psychosis was not supported, not by the findings in this review and not by other recent systematic reviews either.
That is a crucial piece of reassurance.
It is. It suggests that in these critically ill refractory cases, the benefit of that acute reversal really outweighs those feared risks.
What about the immediate side effects, the dissociation that ketamine is known for?
The adverse events were reported as generally mild and manageable. They included the typical things like nausea, vomiting, temporary dissociation, maybe mild concentration or memory problems. But importantly, many of the case reports noted no adverse effects at all.
That's amazing.
And the fact that the side effects were mild in such medically fragile patients is a key finding, especially when safety is the main reason you can't use ECT.
Okay, now for the reality check. This data is incredibly promising. Improvement in every single case. But we're relying on a synthesis of case reports, which is, the lowest rung on the evidence ladder. What are the major limitations here?
You're right to bring that up. Case reports have several unavoidable limitations. First, there's significant heterogeneity.
Meaning the cases were all different.
All different. Different underlying causes, different severities of catatonia, and the ketamine dosing was completely variable. And second, there's the risk of publication bias.
Right. Clinicians are much more likely to publish a success story than a failure.
Far more likely. So what we're seeing is potentially skewed towards success.
So given that, can we ever truly validate this with, the gold standard studies, randomized controlled trials?
That raises a really important question. Given how rare refractory catatonia is and the immediate life-threatening danger it poses, doing a large placebo-controlled trial is exceptionally difficult.
Maybe even unethical.
Perhaps even ethically impossible. You'd be withholding a potentially life-saving treatment. So the systematic synthesis of these case reports, despite all the limitations, it remains vital for guiding treatment. It's the best data we're likely to get, and it helps clinicians make informed decisions in an emergency.
So what does this all mean for you, the learner, listening to this deep dive? The main takeaway seems to be that when the standard GABA-focused tools fail, and when medical issues prevent the use of ECT, NMDA antagonists like ketamine and esketamine offer a fundamentally different strategy.
A strategy that has proven highly effective and rapid acting in this small pool of data.
Yeah.
And if we connect this to the bigger picture, it validates that whole conceptual strategy of switching neurotransmitter pathways when one system fails. It reinforces ketamine's role as a potentially life-saving third-line intervention, and it provides real hope for patients who were deemed treatment refractory.
So this evidence suggests we should see ketamine not just as an innovative treatment for depression, but as a crucial tool for acute neurological emergencies that demand a rapid and potent circuit reset.
Absolutely. The speed and efficacy documented here suggests that for certain refractory patients, ketamine isn't just treating a symptom, it's flipping a switch that releases the brain from a potentially fatal lockup.
If you enjoyed this deep dive into the science behind ketamine, be sure to subscribe wherever you get your podcasts. We'll be back soon with more insights from the cutting edge of research.
Thank you for listening.